Thanks everybody for coming today. We're so excited to come back in person at the Society of Neuro-Oncology and have this great symposium and update on the latest progress in glioblastoma. Thanks everyone for coming. It means a lot to all of us that you're here in person in Boston. We're going to have two great speakers who are experts in glioblastoma, and we'll introduce them shortly. Our panelists, Ahluwalia and Nicholas Blondin. And I want to thank the Medical Learning Institute, Peer Review, and our friends at ABTA for providing this session, as well as Novacure for providing an educational grant for the meeting. For those of you joining us in person today, what you should do is answer polling questions at the beginning and throughout the activity. You'll be using the keypads in front of you. And ask us questions during the Q&A session. What you do is fill out the question cards and then pass them to the staff members. For those of us, and this is a hybrid meeting, joining us virtually, you have already completed the pre-event survey. And then please answer polling questions that appear on the screen and ask us your questions in the space provided. My disclosures are here. And Ahluwalia and Nicholas Blondin. Planning Committee and content, we want to thank PVI, Peer Review Institute, the American Brain Tumor Association, educational partners, and they do not have any relevant financial relationships. So disclosures are there. And this is the URL for the peer review. And you can take time to access a lot of the information is summarized on practice aids that are useful going forward. And the virtual participants can also view the slides and practice aids and apply for credit by clicking on the buttons located in the left-hand panel. In-person participants in the room can visit the URL above or scan the QR code after the event to access these materials. I did want to say I recognize many friends, and I want to give a special shout out to Dr. Eric Wong, who's been one of the pioneers in this field and a key opinion leader. But I see many experts here within the group, so thank you all. So first questions, please, this is straightforward. Just select your degree or certification. We'll have a few seconds for that. Shouldn't be hard. Okay, moving on. Select the category that best describes you. Neuro-oncologist, neurosurgeon, et cetera, et cetera. Okay, thank you. Now I'll get a little more specific. In the care of how many patients are with glioblastoma are under your care and that you're involved with each month. None, 1 to 10, 11 to 20, it goes up over 30, or not applicable for me. Okay. Which of the following practice settings is applicable to you? Academic, community, other, or none of the above? Okay. Now, for patients with glioblastoma receiving tumor treating fields, which of the following factors would contribute in your mind to the greatest survival benefit? 1, I don't know. 2, increasing the frequency setting in the device. 3, decreasing the frequency setting in the device. 4, encouraging patients to wear the device for more than 10 hours per day, or the same response, but increasing that to 18 hours per day, or not applicable for me. So which is the best answer? Okay. Based on adverse event management recommendations, how would you manage a patient with glioblastoma that is being treated with tumor treating fields and develops mild contact dermatitis? Answer 1, I'm not sure. Answer 2, a high dose of systemic steroids. 3, advise the patient to watch and wait, active surveillance. 4, advise the patient to change the transducer arrays less frequently, for example, every week instead of every 3 days. Or 5, prescribe a topical corticosteroid to be applied to the irritated area when changing the transducer arrays. Or 6, not applicable. Okay, thank you. How likely are you to consider referring an eligible patient with a glioblastoma to clinical trials studying new multimodality strategy? Answer 1, I typically do not refer these patients for clinical trials. 2, unlikely. 3, somewhat likely. 4, likely. 5, strongly consider referring patients to clinical trials testing multimodality treatment. 6, not applicable. Okay, so it's my privilege to welcome and introduce our first speaker. Before then, I just want to give a couple of slides on the overview of to frame the problem. So I think we all familiar with glioblastoma, but these are some of the challenges that we have and some of the unanswered questions. Number 1, the age so if there's something about if you're going to have a glioblastoma, the survival rates are much better. If you're in the first bracket, young adult, from 20 to 44. If you're in the 5-year relative survival rate drops from 22 to 9%. If you're in the age bracket of 45 to 54. And then if you're 55 and above to 64, the 5-year survival rate drops to 6%. So something about immunosenescence or senescence. Glioblastomas present unique treatment challenges due to the following. As you know, the localization of the tumor within the brain and nervous system and the sensitivity there, the inherent resistance to conventional therapy, limited capacity of the brain to repair itself, the dispersion and invasion of the infiltrative cells throughout the brain, the blood supply which is disrupted, and ineffective drug therapy delivery due to imperfect angiogenesis, and also by the same token tumor capillary leakage. And so we look at this in terms of treatment goals as gaining local control and also the systemic treatments. So as a surgeon, we're focused on local control. Also radiation will be conformal. Stereotactic radiosurgery has a role. And tumor treating fields, I view this as both locally and as throughout the brain. But then we go to systemic chemotherapy, the biological agents, immunotherapy, and targeted therapy. So our distinguished speakers will be addressing those newer modalities. Today's goal is to look at some of these barriers. And for example, tumor treating field therapy was approved by FDA 10 years ago. It's considered standard of care. yet implementation is very poor in the relatively low in the clinic. Only 3 to 12% of those with newly diagnosed glioblastoma receive the electrical field therapy. And for recurrent disease, it's between 0 and 16%, so quite poor. So we'll hear from Dr. Nicholas Blondin on integrating modern modalities in the management of GBM and how can we best apply the latest science. Yeah. And then we're also going to be looking at Dr. Ahluwalia will be looking at practice guidelines and surveying the horizon, looking at the other innovative therapies that are coming along, and with a focus on clinical trials. And unlike the pediatric population where most children are in clinical trials, for adults, only around 10%, fewer than 11% are actually enrolled in clinical trials. So there's certainly opportunity for improvement there. Dr. Blondin will be talking about integrating modern modalities and systemic therapies in the management of glioblastoma and how we can apply the latest science today. He is on the faculty at Yale and very active in the Smilow Cancer Center at New Haven and Yale. So turn it over to you.
Thank you very much, Dr. Brem. I'll be speaking on tumor treating fields, or TT fields, relatively new cancer modality, although as Dr. Brem mentioned, it's been approved for treatment of glioblastoma for over 10 years. And I'll be reviewing some of the data supporting the use of TT fields. And we also have some video clips on a patient journey with a patient utilizing TT fields, which was done in collaboration with the American Brain Tumor Association. So tumor treating fields, or TT fields, were first introduced into the clinic in 2004. A pilot study was done demonstrating feasibility of treatment. And following that, a study was done in recurrent glioblastoma patients, the EF11 study, demonstrating equivalent survival times for patients treated with TT fields as a monotherapy versus a physician's best choice chemotherapy. That led to the FDA approval in recurrent GBM in 2011. Subsequently, a large study was done in newly diagnosed patients utilizing TT fields along with TMZ in the maintenance phase of treatment after radiation, and this led to the FDA approval for newly diagnosed patients in 2015. More recently, TT fields are being investigated for other tumor types, and there was an approval in 2019 for unresectable mesothelioma, and many other trials are ongoing in solid tumors such as lung, pancreatic, and ovarian cancer. TT fields have been adopted as an NCCN Category 1 recommendation for treatment for patients with glioblastoma. This is the NCCN slide for patients with newly diagnosed glioblastoma under age 70 and good performance status. TT fields are a Category 1 recommendation for both methylated and unmethylated patients. And also for patients over age 70 with good performance status, TT fields are Category 1 for methylated and unmethylated patients. So despite this, the use of TT fields in GBM patients generally still appears to be low. And so we'll be addressing some best practices for overcoming some challenges and barriers to prescribing TT fields for patients with GBM. TT fields are, I like to think of as kind of like a fourth pillar of tumor treatment. You have surgery, radiation, chemotherapy, and now electrical field therapy with TT fields. And these function as an anti-mitotic therapy working during the mitosis or M phase of cell division, with TT fields disrupting the physical process of tumor cell division, whereas radiation and chemotherapy damage DNA and affect cell division at a different phase. So TT fields can be used synergistically with chemotherapy and possibly radiation therapy, as some trials are investigating, which I'll allude to later in the talk. And TT fields has a few different mechanisms of action in cells to disrupt cell division. One of those being inhibition of tubulin polymerization into microtubules by affecting a process called dipole alignment of charged molecules. And a second electrical property known as dielectrophoresis prevents large charged macromolecules from segregating normally from one cell into the two daughter cells. At this point, we'll show a brief video further describing the mechanism of action of TT fields.
In metaphase of cell division, cells are a rounded shape as the mitotic spindle forms. Intracellular components such as macromolecules and organelles are naturally charged. Tumor-treating fields, or TT fields, disrupt cancer cell division by physically interacting with molecules required for mitosis. When alternating electric fields are applied to cancer cells, they disrupt microtubule polymerization. Tubulin dimers align with the electric field and are not able to form microtubules. This prevents the organized assembly of the mitotic spindle required for normal cell division. The inhibition of microtubule formation leads to metaphase arrest and cancer cell death. In addition, these deformed microtubules can lead to abnormal DNA segregation between daughter cells, which also results in cancer cell death. TT fields can also affect cells after metaphase. If a cancer cell has passed metaphase and enters the cytokinesis phase, the cell takes on an hourglass shape. This state under TT fields creates a non-uniform electric field inside the cell, creating dielectrophoresis. Net forces push the macromolecules and organelles toward the mitotic furrow, and this disruption leads to structural disorganization and cancer cell death.
TT fields have been found to be biologically effective in disrupting cell division of numerous different cancer types, and there is an optimal frequency of the electrical fields to achieve tumor cell kill. In GBM, this is 200 kilohertz. TT fields are delivered via a medical device consisting of 4 rays that are placed on the patient's scalp, delivering opposing electrical fields between 2 sets of arrays, and the arrays are connected via an adapter to the device, which is portable, powered by a battery, or plugged into a wall outlet. Treatment can be individualized for a given patient using a mapping system, which can provide the optimal array placement on a patient's scalp. And by optimally placing the arrays, you can intensify the electrical field in the region of the brain where the tumor is. And preclinical studies have demonstrated a higher field intensity leads to better cell kill. I'll now review the EF14 study, which was the pivotal trial for treatment of newly diagnosed patients. And in this study, patients with newly diagnosed glioblastoma would complete standard 6 weeks radiation and temozolomide chemotherapy and then be randomized in a 2-to-1 fashion to receive TT fields with temozolomide or TMZ alone as a monotherapy. As you can see, there were 466 patients in the TT fields plus TMZ arm and 229 patients in the TMZ alone arm. The primary endpoint for the study was the time until the first progression, and the secondary endpoint was overall survival. Patients in the TT fields arm could utilize TT fields following first progression until the second progression occurred, or 24 months. This study demonstrated a significant overall survival improvement in patients and the intent to treat population. So patients randomized to the TT fields plus TMZ arm had an improvement of their median overall survival of 4.9 months, improved from 16 to 20.9 months. When adding the time between surgery and their initial radiation and chemotherapy, patients in the TT fields plus TMZ group survived a median of 24.5 months versus 19.8 in the TMZ alone arm. And again, as you can see with the survival curve, the curve separates essentially at time point 0, and that separation is maintained over time. There was a higher rate of 5-year survivors in the TT fields group. This improved from 5% to 13% of patients. Subgroup analysis demonstrated that all subgroups appeared to benefit from TT fields treatment. In particular, I'll point out that methylated patients had an increase in median survival time of over 10 months, improved from 21.2 to 31.6 months. Also, patients with any extent of surgery benefited from TT fields treatment. Patients in younger or older age group benefited, likely leading to the NCCN designation. And I'd also like to comment on the usage of TT fields for recurrent GBM. As I mentioned, this was approved in 2011 from the EF11 study comparing TT fields alone as a monotherapy versus physician's choice chemotherapy. In that study, the results were in the intent to treat population. Subsequently, a modified intent to treat population was examined. In this group, the patients that utilized TT fields for at least one cycle of treatment, or 28 days, were analyzed. Patients utilizing TT fields for less than 28 days were excluded, approximately 20 patients. And in this modified ITT population, there was a statistically significant improvement in survival. In the EF14 study, in newly diagnosed patients, quality of life measures were collected during treatment, and the use of Optune was found to not have any detrimental impact on quality of life. In fact, data showed that patients had a longer time until neurological deterioration and lengthening of quality of life in the TT fields arm, likely as a function of improved progression-free survival. Specific TT fields directed quality of life measures are now being looked at. There were 2 abstracts here at SNO analyzing this as seen in the blue box. TT fields were found to have improved overall survival advantage with higher rates of use. As one would expect, TT fields have biological activity when they are being applied to the patient. So the more time that the tumor cells are exposed to TT fields, the better the survival outcome was found to be for patients. In the EF14 study, a majority of patients utilized TT fields from 70 to 90% of the time. A smaller percentage of patients were able to utilize more than 90% of the time, but it was found that a survival advantage occurred starting at 50% of the time, at least. As per the labeling, TT fields are indicated for use at least 75% of the time. Now we'll just comment on a patient's journey. As I mentioned, we partnered with ABTA for this presentation. And Mary is our patient who has been utilizing TT fields therapy. She was diagnosed with GBM in September 2018 after experiencing stroke-like symptoms. Following her diagnosis and surgical resection of her methylated IDH wild-type tumor, she started TT fields after completing standard radiation. Now we'll hear from Mary on her experience of utilizing Optune.
I row on the Charles River.
Oh, wow.
In like a single or a double rowing shell. So I don't bring the backpack with me in case the boat flips. So some days I just unplug from this thing on my waist. I just unplug these 4 ports and I wrap this wire around my head, and then I put a buff or a scarf to hold them in place while I row. And I leave the backpack in the locker. And then when I get off the water, I just re-plug in and I turn everything back on, and I don't lose any time of treatment. Very little time. If I'm only on the water 45 minutes or an hour, I've only lost 45 minutes, which is not too bad. And then I've got the drive time of treatment. And then I've been doing pretty well. I've been getting like 80%, 87%, 86% usage every month.
Great.
Yeah.
Really sounds like, there are some parts of this therapy that have impacted your day-to-day, but you haven't let it take away the things that you enjoy, like camping and rowing. You just found ways to adjust so that you can still get this therapy, but still do the things that mean a lot to you. So your quality of life is still there, and you're enjoying what you're doing. Would you agree with that?
Yeah.
All right, now we're going to look at a follow-up to poll question number 1. And you're asked to rethink your choice. For patients with GBM receiving TT fields therapy, which of the following factors would contribute to the greatest survival benefit? All right, correct. I'd like to touch on some emerging strategies to further advance treatment for GBM patients. TT fields are being looked at in newly diagnosed patients used in combination with radiation therapy, initiating treatment with TT fields at the time of radiation initiation. Pilot study has been done demonstrating feasibility of this. TT fields are also being investigated for use with immunotherapy, such as pembrolizumab. Dr. Tran gave a really interesting abstract last night on his To the Top study, demonstrating feasibility of treatment with pembrolizumab and TT fields. And TT fields may disrupt the cellular membrane or enhance the immunological effects. In regards to combining TT fields with radiation therapy, TT fields and radiation have complementary and non-overlapping mechanisms of action, affecting tumor cells at different points of cell division. With this, it again is hypothesized that initiating TT fields along with radiation therapy may provide even better outcomes for patients. And this is being investigated in a phase 3 study termed the Trident trial, TT fields plus concomitant radiation, followed by TT fields plus TMZ maintenance. In this, patients with newly diagnosed GBM randomized in a one-to-one fashion to receive TT fields at the start of radiation therapy, followed by continuing TT fields with maintenance TMZ, versus the conventional way of doing radiation and temozolomide and then initiating TT fields with maintenance temozolomide. The primary endpoint of this study is overall survival, and 950 patients are planned to be enrolled. This study is actively enrolling. In regards to adverse events seen with TT fields therapy, the most common adverse event is skin irritation. This is on the scalp where the arrays are placed. The most common irritation or most common diagnosis seen is pruritus or itching. Patients may also experience hyperhidrosis, excessive sweating, or ulcerations and erosions, a more serious skin condition if patients experience more significant skin trauma. For pruritus or itching, treatment can be done with topical steroid treatment and trimming the arrays to decrease the amount of the adhesive contact in the patient's scalp. Moving the arrays with each array change also can decrease some skin adverse events, as demonstrated in the picture on the left, on the right. Now we'll watch a short video of Mary describing the measures that she takes with array changes.
Sounds like you're having to make decisions and make plans around the therapy.
Yeah, around the shower, and then so they have to come off, and then I have to get a shave again every time. And then we try to get all the glue off with witch hazel or alcohol. Alcohol's a little harsh. And then put cortisone cream on so it's not itchy. And then trim the arrays, the pads, and then they go on.
So now I have a follow-up for poll question 2, based on AE management recommendations. How would you now manage your patient with GBM being treated with TT fields therapy who has developed mild contact dermatitis? Great, yes, the recommendation would be prescribe a topical corticosteroid to be applied to areas of irritation during array changes. And Mary also mentioned that in her particular case, she does some array trimming. Some concluding thoughts. I kind of like to offer my perspective on treatment of patients with TT fields. A common patient concern can be just experiencing information overload, feeling like TT fields seem like a lot to understand, a complex system to use, and I try to help patients understand there's a learning curve associated with the medical device, and it gets easier with time. Like most things in life, it becomes much easier with practice, and I try to not let patients feel discouraged right at the start of treatment and give them a pep talk to try to utilize devices as much as possible and try to improve month after month from there. Some patients may also express reluctance to shave their hand, a perfectly valid concern. I empathize with the patient, and you can normalize this for patients. Most patients do wear some kind of covering over their head where the arrays are, such as a hat or a scarf. Wigs can also be worn, particularly if loosely woven. And then some patients will have a fear of being a burden to their caregiver or feeling like the treatment will require a lot of work and they don't want to make their caregiver responsible for that. But again, I think it's important to empathize with the patient, and you can consider a caregiver pool. Maybe like a few individuals could be assigned to help with the array changes. And again, help patients recognize that with appropriate use of TT fields, this can delay progression and maintain quality of life for a longer period of time. And finally, if patients feel overwhelmed about using the device for the prescribed amount of 75% of the time, again, remind patients, practically speaking, the arrays are placed on the scalp essentially all times except during array changes, and then the treatment is being actively delivered when the device is turned on. So if worn at nighttime, that's already 50% of the time of a 24-hour period, and that can kind of help patients understand if they need to take breaks to do activities such as rowing, you have time banked up to do that. So now we'll watch a short video of Mary provide some concluding thoughts, and following that, we'll pass to Dr. Ahluwalia.
Knowing what you know now, what advice would you give to other patients that might be in your shoes that are exploring treatment options and trying to make that decision?
I mean, I think I've surpassed my projected life expectancy. So that's what you have to weigh, is maybe beating the odds and having, longer life, and continue maybe doing what you love, but do it with modification. Like, I love rowing, but I think I've made it that I'm just as happy doing yoga.
All right, so it's a great pleasure then, that was so moving, to continue with Dr. Mamit Ahluwalia, who's Chief of Medical Oncology, Chief Scientific Officer, and Deputy Director of the Miami Cancer Institute, and a great thought leader and opinion leader in the field, who will give us an overview of what's in store for us as clinicians and our patients to improve glioblastoma care and outcomes. Mamit?
Thank you so much to everyone for coming here today. Thank you to Dr. Brem for asking me to talk on glioblastoma and what's on the horizon. And would like to congratulate Dr. Blondin on a very eloquent and a comprehensive talk on tumor treating fields.
Thank you.
So as has been spoken before, glioblastoma, we have limited treatment options. And what they are, as has been outlined by Dr. Blondin, is also on the slide, which is when patients get diagnosed, they need to undergo maximal possible safe resection, which is typically followed by radiation with concurrent and adjuvant temozolomide, along with tumor treating fields. And you saw the recommendations based on the NCCN guidelines that Dr. Blondin went over. Unfortunately, despite this, most of our patients actually progress within 6 to 9 months of diagnosis. And there are a number of therapies that have been outlined here, which include bevacizumab. Sometimes our patients can be re-challenged with temozolomide with alternating schedules, metronomic dosing, depending on how long are they away from the initial diagnosis. We use other alkylating agents that include lomustine or carmustine. There have been combinations of procarbazine, carmustine, and vincristine that has been used. Regorafenib is often a modality that has been recommended based on a Spanish study that I'll go on. And then we know there are certain tumor types in glioblastoma. There's subtyping of the tumor where they may have a gene fusion. And we know there are 2 drugs which are being approved on the basis of the pan tumor based on NTRK gene fusions, which include larotrectinib and entrectinib. There is, previous therapies like etoposide or platinum-based therapies, which have been used in patients who live long and have utilized some of these other modalities. And there is some interesting data coming with BRAF and MEK inhibition in those patients who harbor the BRAF V600 activating mutations. And we do know that the combination of BRAF MEK inhibition is generally better with BRAF inhibition alone because MEK is the most common pathway of resistance. So you have combinations of dabrafenib, trametinib, or vimbrafenib along with cobimetinib. So this is the study which was led by Wolfgang Wig, was done to the EORTC group, and essentially really outlines the couple of treatment options that we have for our patients as standard of care if they progress. And as we discussed, unfortunately, most of our patients progress despite initial treatment. And this was a study which was exploring the benefit of bevacizumab along with lomustine compared to lomustine, which has been pretty much been the de facto standard of care for our patients over several years. This was a 2:1 randomization, and as you can see, close to 300 patients were treated with the combination of lomustine and bevacizumab compared to around 150 patients who got lomustine alone. And as you can see, pretty much overlapping curves, the blue curves demonstrating the benefit with lomustine and bevacizumab, and the red curves with lomustine alone, pretty much showing very comparable overall survivals in the ballpark of 9 months. So essentially, based on this, a lot of patients have been treated with lomustine again, and lomustine has pretty much become the comparator arm for most of our trials. And as you can see, this was a phase 2 trial called REGOMA, which was done in Europe. And essentially here, regorafenib, basically, which is a drug that targets, it's a multikinase, tyrosine kinase inhibitor that targets VEGF, but also targets a number of other things, including PDGF, KIT, was shown to have a better survival compared to lomustine. And there was some benefit even with progression-free survival. One caveat here to consider is actually that the benefit of overall survival in the regorafenib arm was 7.4 months compared to lomustine, which was 5.6 months, slightly lower than some of the recurrent glioblastoma outcomes that we have seen, and as you saw in the previous slide. But nevertheless, a drug which adds to the armamentarium of what we have for our patients, and we are looking at this drug in a number of trials right now. So essentially, as Dr. Brem had outlined, and as we saw in the NCCN guidelines, the number one recommendation for any patient with glioblastoma is consideration of a clinical trial. That we have this dubious distinction of being a very rare tumor type where clinical trial recommendation is above standard of care. If you open this NCCN compendia, most of the times it's standard of care or clinical trial. In our case, its clinical trial is even higher. It's the preferred option for eligible patients. Despite that, fewer than 11% of our patients in glioblastoma enroll in clinical trials. And there are a number of reasons why this is the case, and we need to work together to improve patient access because a lot of patients live far away from centers of excellence, which typically have these trials. And so definitely improving patient access can help us bridge that gap. Often we have been criticized in recent years for making a criteria too restrictive, and that limits a lot of patients getting onto the clinical trials. And the other challenge that we have in glioblastoma, and it's one of the key takes away, if you will take one away from this talk, is that there is no agent that has ever shown any survival benefit in recurrent glioblastoma till date. And so unfortunately, a lot of times when you look at pharmaceutical drug development, it typically starts in the recurrent tumor type, and then it moves to upfront, because that's probably the easiest space to develop a drug. But hence, in our case, most drugs that have even succeeded in the upfront setting did not show a survival benefit in the recurrent setting. Temozolomide, tumor treating fields, radiation. So a number of agents unfortunately fail in the recurrent setting and hence are abandoned in the upfront setting. So this is an example of one of the efforts that's going on. This is GBM Agile. There are around 34 centers in the United States which are participating in this trial, and overall, globally, there are over 50 centers now. It's an adapted phase 2/3 adaptive design, and regorafenib, the study that I went over, the REGOMA study, which showed some survival benefit in recurrent setting, was actually the first experimental drug which is ongoing right now. And there are two additional agents, paxiliflozin and VAL-083, which are also being looked at in this trial option, and a number of agents are actually being considered to be brought on through this mechanism. INSIGHT was an effort led by Patrick Wen, Brian Alexander through the Dana-Farber, and there were 10 institutions which were part of this effort. And this was to go after the newly diagnosed unmethylated GBM. As you know, temozolomide confers a very limited benefit in this patient population. Actually, there is a 24-day benefit if you give an unmethylated MGMT patient temozolomide. So hence, there was an effort through this group to look at new therapies based on genotyping for biomarker subtyping, looking at the CDK pathway or the EGFR pathway or PI3 kinase pathway. And essentially, depending on what the genotype of the patient would be, they were assigned to the experimental arm. The control group was a standard radiation plus temozolomide followed by 6 cycles of adjuvant temozolomide. So abemaciclib arm was looking at patients who harbor the CDK alterations, where patients got radiation temozolomide followed by adjuvant abemaciclib. There was actually the presentation which showed that there was a progression-free survival benefit with this drug, but unfortunately there was no OS benefit. Then CC115 is a dual mTOR inhibitor, and essentially this was looking at the PI3 kinase pathway. And then neratinib arm included those patients who harbored the EGFR alterations. And as you know, neratinib is a drug that's approved for HER2 altered patients with breast cancer. This trial just was presented in the previous clinical trial session, which just concluded, and essentially there was no benefit with neratinib in progression-free survival in this arm compared to the control arm. But one of the things that we have been excited in the last few years, especially, has been gene fusions. And as I talked to you about, that there are several tumors that actually harbor gene fusions. And in glioblastoma, actually, Antonio Overon actually led this effort when he found out about the FGFR TAC3 gene fusion, which was a science paper in 2012. And what he showed was that FGFR TAC gene fusion is present in around 3 to 4% patients with glioblastoma, and since then, numerous papers have shown that this is the same number for other gliomas too. But there are other gene fusions which include EGFR, CEP14, there is definitely the NTRK gene fusions and the MET gene fusions. And this is basically data about larotrectinib, which is one of the 2 drugs that I spoke to you about, which actually have a pan-tumor or a tumor-agnostic approval based on any patients that have an NTRK gene fusion. And this is the data in primary gliomas. If you look at the larotrectinib data across all tumors, so the most common NTRK gene fusions are actually found in salivary gland tumors. And most of the other tumors, the response rates with larotrectinib is around the ballpark of 80%. If you look at CNS metastases, the benefit with larotrectinib is around 50 to 60%. When you actually look at primary CNS tumors, the response rate is 36%. But still, this is much better than the 5% response rate that we are used to seeing with cytotoxic agents like lomustine. So definitely another drug in our armamentarium for this patient. This actually highlights the need for genotyping or molecular profiling in our patients, because we are now when you look at patients who harbor NTRK gene fusions, it's been described to be 1% for patients with glioblastoma, but 8 to 13% with patients with pilocytic astrocytoma. So essentially, it can be an option for those patients who have these alterations. And this is the other drug called entrectinib, which is basically an inhibitor that targets not only the NTRK gene fusion, but also the ROS1 alterations. So this is the data that was presented with CNS metastases. And this was 12 patients who harbored CNS metastases at baseline. And then there was always also a group that did not have CNS metastases as baseline. It's really gratifying to see at least that CNS metastases patients are now being included in clinical trials, because a decade back, generally these patients were actually excluded from all clinical trials and had to wait for like a drug to get approved before we could give it to our patients. But here you can see the response rates in the ballpark of 60%. Very comparable response rates have been seen with larotrectinib in this patient population as well when we look at CNS metastases. Now going on the MET gene fusions, this is found in around 2 to 2.5% patients with glioblastomas. Actually, typically tend to occur more in patients with secondary glioblastomas. And this was a study that was published in Cell a few years back, and was actually a study done in China, where they actually showed that at least in 6 patients with secondary glioblastoma who were evaluable, 2 patients achieved a PR, 2 patients had stable disease, and 2 patients had progressive disease. On the basis of this, there's an ongoing trial right now called SPARTA, which is looking at this drug APL-101, where they are actually looking at outcomes of this agent in patients with lung cancer who have MET14 skipping alterations, but also are looking at pan-tumor types in patients who have MET gene fusions as well as MET amplifications. So definitely an option for patients who harbor these alterations. A slide about the BRAF MEK inhibition in glioblastoma, as I had earlier alluded to, according to the new NCCN guidelines. Now, this is an option for our patients, and this is based on a couple of basket trials looking at vemurafenib, where the overall response rate was 43%, progression-free survival around 6 months. And then there was another trial looking at dabrafenib and trametinib, where the overall response rate was 56%. We have seen this to occur even in melanoma patients with brain metastases. If you use a BRAF inhibitor, you have some response rate, but when you use a BRAF and a MEK inhibitor, you actually have a better outcomes. And similarly has been described with patients who harbor these alterations. So what are the challenges in glioblastoma? So we will focus on a couple of aspects. Obviously, this has been theme of presentations in the last few SNO meetings. One is an approach targeting EGFR. The other one is targeting immunotherapy as a whole. And as you know, EGFR is altered in 50% or so patients with glioblastoma and has been a very active area of interest. We also know the V3 variant is an extracellular domain truncation that occurs in around 25 to 30% of patients with glioblastoma, and essentially can lead to constitute activation of that pathway, leading to cell proliferation and growth of the tumor cells. So this is a fairly busy slide, but essentially the take-home point here is that all of our efforts looking at tyrosine kinase inhibitors that have actually been successful in lung cancer, and even in lung cancer brain metastases, unfortunately, including gefitinib or erlotinib, have all been negative in glioblastoma trials. Same thing was there for cetuximab, which is basically a monoclonal antibody that targets the EGFR pathway, and nimatovimab, which is another monoclonal antibody that targets the EGFR pathway. There was a lot of hopes for rindopipimid based on some of the early trials that were done through the Duke group, where we had seen very nice overall survival benefit when we looked at historical controls. Unfortunately, when the phase 3 trial resulted, there was no benefit of using rindopipimid in patients who harbor EGFR V3 variants, and this trial was unfortunately negative. Then in SNO 2020, this was one of the plenary presentations by Dr. Andy Lassman. This was a study that was run through the RTOG Foundation, the RTOG 3508 trial, which basically looked at this antibody drug conjugate, where you are using essentially the EGFR pathway as a Trojan horse to get into the tumor, and this was combined with a cytotoxic. And essentially, although there was some glimmer of hope, again, looking at this modality in recurrent glioblastoma, there was no benefit in either progression-free survival or overall survival in all the tumors when we looked at this. And unfortunately, the trial failed to meet its primary endpoint. There was one takeaway that there was some progression-free survival benefit in those patients who had EGFR V3 variant. This is hypothesis generating. There was a p-value of 0.02, but unfortunately, the overall survival, again, in this subgroup, post-hoc analysis did not show any difference, both the groups living around 18 to 20 months. So there are still a number of trials which are looking at still EGFR. It's still a pathway. There are some small molecule inhibitors which are being developed, which may be more selective to the alterations as they occur in glioblastoma compared to lung cancer. There are these antibody fragment immunotoxin, the C2, C7, CD study. There is CAR-T efforts which are being developed, work done actually from Dr. Brem's home institution with Carl June's efforts there, who's really done some revolutionary work in CAR-T, at least in the heme malignancies. And the question is, can we translate this into solid tumors, which I think is a little bit more difficult tumor type to treat compared to heme malignancies, but definitely a lot of excitement about these CARs being developed for these patients with EGFR V3 variants. Similarly, there are BiTEs, which are bispecific T-cell engagers. We've got BATs, which are bi-armed activated T-cells going after these patients. And then we have newer ADCs from companies like AbbVie looking at EGFR alteration, including the ABV 321, and then there are other efforts looking at intra-arterial infusion. We tried that with bevacizumab before, and there are efforts looking at that with cetuximab, which is a monoclonal antibody against the EGFR. So and then there is obviously an effort looking at checkpoint inhibitors. We know in the rest of the cancer space, a number of tumors have been really have had groundbreaking results because of immune checkpoint blockade. And a classic example of that is lung cancer. Almost 2 decades back, patients with stage 4 lung cancer had very similar outcomes like glioblastoma in the ballpark of 12 months. And less than 5% of patients with lung cancer, stage 4, were alive at 5 years, as Dr. Brem had shown for glioblastoma. And now more than 20 to 25% patients with stage 4 lung cancer are alive at 5 years. So they've had a dramatic change, and most of it has been driven by targeted therapies or checkpoint blockade. Unfortunately, in glioblastoma, as you'll see in my following slides, we've not had that kind of success. Although there are a rare subset of patients with glioblastoma where they have this hypermutation or high tumor mutational burden because of germline biallelic mismatch repair deficiency, they can be really a great candidates for immune checkpoint inhibition based on some work coming from Yale group and actually also work coming from the Toronto group with Eric Buffet and colleagues. So we've had 3 large phase 3 trials which looked at this drug called nivolumab, which targets the anti-PD-1 pathway. The first trial was the Checkmate 143, which was an effort in the recurrent glioblastoma space. The second one was the Checkpoint 498 study, which was an effort looking at the unmethylated MGMT. Here we looked at just radiation plus nivolumab, comparing it to temozolomide and radiation. And the presentation we haven't seen it, but there was a press release showing that the study failed to meet its primary endpoint, unfortunately. And Checkmate 548 was presented at this conference. So this is the Checkmate 143 study looking at nivolumab, comparing it to bevacizumab in patients with recurrent glioblastoma. And here you can see it was 1-to-1 randomization, a study of close to 300 patients. And you can see here, again, overlapping curves with blue with nivolumab, with bevacizumab, which is in the red curves, a hazard ratio of 0.04, and no survival benefit with nivolumab and bevacizumab compared to bevacizumab. And the OS outcomes in both the group was around 10 months. This was the Checkmate 548, which was a plenary here yesterday. Dr. Michael Weller actually presented the results of a fairly large trial of over 700 patients. And here you can see, again, median progression-free survival of 10.6 months with nivolumab, very comparable to the 10.3 months that we saw with the standard of care arm with radiation and temozolomide. And similarly, the median overall survival with nivo, radiation, and temozolomide was 29 months compared to 32 months with radiation and temozolomide. One thing exciting, though, to see, at least in this group of patients who are being put on clinical trials because of all the supportive care, advancements in surgeries, radiation, and our ability to manage our patients overall in their toxicities, at least the survival curves are moving a little bit to the right. With the caveat that patients, when we look at SEER data, do not have these survivals because a number of our patients are not eligible for clinical trials based on performance status. But at least we're moving the needle jointly. So what are some of the challenges that exist with checkpoint inhibition? Dr. Weller made a point yesterday after his presentation that maybe anti-PD-1 may not be the right target, but there are at least some excitement about the CTLA-4. And we know, at least in other tumors like melanoma, that a combination of CTLA-4 with anti-PD-1 may be a better effort. There's a trial going through the NRG mechanism called the BN007 trial, which is looking at combination of ipilimumab and nivolumab in patients with unmethylated MGMT glioblastoma. This was a study that I was involved with and I led through in collaboration with my colleague here, David Pierboom, who's in the audience. And here we looked at nivolumab plus bevacizumab because there was work out of Rakesh Jain's lab in Mass General that maybe using low-dose bevacizumab may help control the need for steroids, which we have found is a major challenge in our patient population because most of our patients, because of mass lesions, are on steroids. And we know steroids don't work well in patients who are being put on immune checkpoint blockade because you're trying to boost the immune system with your therapy, and we know that steroids actually lower your immune function. So we looked at this effort comparing nivolumab with bevacizumab in the standard approach and looking at nivolumab with low-dose bevacizumab, and we had a poster presentation last night. Unfortunately, the outcomes in both arms were very comparable and were not very different than what we've seen with nivo alone or bev alone. So a valiant effort of a collaboration between Cleveland Clinic and Dana-Farber not much difference overall. Although what we presented in the poster yesterday, that there may be benefit with the standard dose bevacizumab along with nivolumab in patients who are over 60 years of age. Again, post-hoc analysis, so you have to take that with a grain of salt. Hypothesis generating at best. Maybe there is some aspect to immune function in elderly that we may be able to target with immune checkpoint blockade. This was an effort led by Tim Clausey through the IV group, looking at neoadjuvant anti-PD-1 immunotherapy, looking with pembrolizumab, a relatively small randomized trial of 16 patients to cohort A and of 16 patients to cohort B. One group got actually neoadjuvant pembrolizumab before surgery, and the other group got just adjuvant pembrolizumab. And here you can see very nice separation. Now, this is the basis of an upcoming trial that may explore this effort more going forward. Then Dr. Blondin did a great job talking about the studies. Dr. David Tran's trial looking at tumor treating fields along with temozolomide and pembrolizumab, which was actually presented here. And you can see the abstract. The median follow-up of 15 months with 25 evaluable patients basically showed that progression-free survival was around 11 months compared to 7 months in control. Again, hypothesis generating, needs to be explored more in a larger trial. So given all this information, and I gave you a lot of information today, how likely are you now to consider referring eligible patients with glioblastoma to clinical trials studying new multimodality strategies? Thank you. Well, I'm at least excited to see that of the people who are eligible, most people still, are looking to recommend clinical trials for their patients, and not much sentiment has changed despite seeing some of the negative data. I would make the caveat, there was actually a paper out of University of Cincinnati a while back that actually showed that even patients who went on the placebo arm of a trial actually did better when you compared them to the standard of care, because we know there's a placebo benefit. So again, in our field, I think we still need to refer patients to clinical trials. I think we need to do a better job in biomarker development, because a lot of times we know glioblastoma is a very heterogeneous tumor, but we still try to give one drug and hope that it'll make a difference. So I'm particularly excited by some of the gene fusion studies, because I think that is probably a relatively low-hanging fruit, and as we've seen with NTRK gene fusions and some of the preliminary data with MET gene fusions, and maybe an avenue for us to explore more in clinical trials. Passing it back to Dr. Brem to reflect on what we find out with our talk today and interactions.
Thank you so much. Beautiful job, both speakers covering a tremendous amount of information. I just want to reinforce your last point that there is data that just by being on a clinical trial promotes survival, even if the agent being evaluated ultimately proves ineffective. Whether it's the intensity of medical care, placebo effect, I'm not sure, but I always urge all my patients to be on a clinical trial. So these are some of the major points that we're going to ask you to check the best answer. So tumor treating fields is an important treatment option to recommend in addition to standard of care. Survival benefit with tumor treating fields is directly related to patient compliance if the device is worn more than 18 hours a day. And managing the dermatological adverse events can be benefited by prescribing corticosteroids, repositioning the transducer rays that could arise from the TT fields. And novel multimodal strategies with systemic therapies demonstrate promising clinical evidence for patients with glioblastoma. And finally, all of the points above are important and likely to inform my practice, or finally, not applicable for me. So. Also, what left the biggest impression on you today? What did you learn during the program? And it looks like 69% chose question 5. All of the points above were important and will inform my practice. So happy to see that. And we're going to get to 4 questions, and I'm going to distribute them equally, 2 and 2. I just want one more important acknowledgement that I omitted, and that is Dr. Hamza Jagannathan has really been terrific to work with our speakers and curate a tremendous amount of information in our field into this 1-hour presentation. So thank you. So I'm going to give the first 2 because they center on tumor treating fields to Dr. Nicholas Blondin. Mm-hmm. And one question is, has 2 parts. How do tumor treating fields actually affect normal healthy cells? And has it been used in medulloblastoma? If so, how does it work in the pediatric medulloblastoma? And how does it affect healthy cells?
Yeah, well, commenting on the first part of that question, it appears that tumor treating fields do not have any direct significant toxicity to healthy cells. I believe the device was, or the treatment of TT fields was initially devised for brain cancer treatment because the brain typically does not have dividing cells in adults. But further studies, starting with pilot studies and other tumor types such as lung and pancreas cancer, demonstrated that TT fields appears to be safe in treatment of other regions of the body. So I guess that's how I'll answer part number 1.
So the brain is an arresting state. It's a quiescent GO organ. So this is great therapy because it affects antimitotic. Normal brain cells are not mitosis. They do a lot of. The
cell size does have an impact on the efficacy of the treatment. As I mentioned, TT fields applied at 200 kilohertz is most effective to kill GBM cells. For non-small cell lung cancer, it's 150 kilohertz. And then for other tumor types, the cells are different sizes and there's a different optimal frequency.
The second question for you, Nicholas, is why is head shaving so important and what work is being done to eliminate the need for shaving the head?
Essentially, head shaving is critical to be able to apply the array directly to the skin. You want to have a patient have direct contact with the transducer array. The fields currently are generated through ceramic discs in the array. Underlying the disc is a hydrogel product, and that needs to be applied directly to the skin because if there is some space, for example, if the patient's hair starts growing, stubble develops, and the arrays are pushed off the scalp, that small amount of space, even a millimeter or 2, with air in it, has very high resistance to electrical fields, and we'll have to make the arrays have to essentially work harder to deliver the electrical fields or heat up. So the device has safety mechanisms to essentially turn off if it's sensing overheating, and overheating alarms could occur if the arrays are not directly applied to the skin.
Actually, there's a third question for you, and then we'll go to Dr. Murray. Do you know the mechanism of resistance acquired to TTF, and what about oxidative stress in glioblastoma, and does that relate to the response to TTF?
There's been some interesting work on mechanisms of resistance. There, I believe, are some case publications about patients that progressed following TT fields treatment, and in a report I'm aware of, the cells had changed size and had become much larger, and it's hypothesized that at that larger cell size, they were less susceptible to the fields. Another mechanism of escape could be tumor development in other regions of the brain where there's lower electrical field intensity. So as I had mentioned, the arrays can be optimally placed to deliver the treatment at highest electrical field intensity a certain region, and there are reports of tumors developing in other regions of the brain. I saw a poster last night about that. That's one thing that has been identified.
So we're going to transition to Dr. Ahluwalia, and these are about other modalities. Can you tell us about IDH as a target and what inhibitors are effective for glioblastoma?
Yeah, sure. So we did not cover that part because according to the new WHO classification, IDH mutant tumors is actually going to be moved out of glioblastoma, and there's going to be a separate classification for these tumors. And there has been a lot of interest about the IDH, and there are a number of modalities which are going about IDH. So Michael Platten has a very interesting vaccine that targets the IDH, which has shown some very interesting results, actually. There are IDH inhibitors, which are targeting IDH1 or 2. We do know IDH inhibitors are approved for other cancers, including leukemia and cholangiocarcinomas, and these trials are ongoing looking at these modalities. There are a number of companies which actually have IDH inhibitors. Then there's also a line of thought that which is being led by Dr. Ranjit Bindra from Yale, that the PARP inhibition actually can use the BRCA nest that exists in patients who have IDH mutant tumors. And there are a number of trials looking at that with olaparib, either alone or in combination with temozolomide. There was an ABTC study which was just presented today by Dr. Schiff, the ABTC 1801 study, which looked at another IDH inhibitor along with combination with temozolomide. So there is a lot of excitement about these tumors. The trials are early on, but definitely we know that we have to really get to the point that these tumors are truly heterogeneous, and IDH is definitely a target that we can go after. So stay tuned for more information in the upcoming meetings of those results.
And the final question, in the interest of time, is a pretty broad, open-ended question, but what other modern modalities are being studied in phase 1 and 2, 3 in trials? I think you covered so many, but are there any other modalities that you want to discuss?
So one, I mean, obviously, we just presented, in the previous session, I presented a phase 1 trial that we did at Cleveland Clinic looking at ruxolitinib, which is a JAK-STAT inhibitor. Amy Heimberger and her group has looked at the VP1066, which is another drug which is blood-penetrant JAK-STAT inhibitor. And our results were quite, impressive, obviously, with the caveat this was a phase 1 trial. I'm using that trial because you mentioned the word phase 1. And the survival that we saw in unmethylated MGMT glioblastoma patients was around 18 months, so which is at least better than what we see with the historical controls of 12 to 13 months. But there are a number of other agents which, looking at particular pathways. I think gene fusions is very exciting for me. There are trials which are looking at FGFR gene fusions, which occur in around 3 to 4%. I think molecular profiling will be important because now when we start adding these small percentages, we can suddenly, if you say, look at FGFR, which occurs in around 3 to 4%, you look at MET gene fusion, which occurs in around 2 to 2.5%, and then you add on NTRK gene fusion, which occurs in around 1%. I think this adds up. So suddenly now we have 6 to 7% of patients with glioblastoma who may harbor the gene fusions. And gene fusions are a great target to go after compared to someone who has a mutation or compared to someone who has an amplification. So I think I'm excited about those trials. But, again, that is why we do this. We offer the best trials to our patients with the hope. And even as Dr. Brem had outlined, I will say a key takeaway. Our trials may not meet their primary endpoint, but we all have had patients, those few patients who've done remarkably well for that trial. For that patient and their family, that was a home run. And for me, personally, the whole study is successful because you made a difference in that patient's life.
And I'm going to put in a plug for a trial that's open now throughout the nation through NRG, a trial I developed with Dr. Steve Bagley, who from our place at Penn, who's the national PI on targeting IL-6, which is a key cytokine for the immunosuppressive environment, and which in preclinical data targeting IL-6 has extended survival in animal models. It's also combined with PD-L1 and with stereotactic surgery. So we hope that yields some interesting information. I think we're coming close to the end of this meeting, and please remember to submit your post-test and evaluations for credit. If there's anything else we missed, then all of this is online at the following URL. You can access this activity in the next 24 hours, and you can also download slides, practice aids by clicking the buttons in the left-hand side of the panel. And for those of you in the room here, please access the slides and practice aids by visiting the website or scanning your QR code. And also, you can also join conversation, of course, on Twitter at PeerView. So thank you all for being here today. It was really great. Thanks so much.